real area of exposure for surgeons is the area of non-compliant patients. It's almost as if we have an epidemic of non-compliant patients. And it can be very problematic with bariatric surgery where you really need to count on the patient to do certain things, not just the patient and their family. Bariatric surgery is sort of unique in that respect. It takes the whole team working together to optimize your outcome, but the patient is a very big part of that. Sometimes, we're not sure why, patients are non-compliant. It can be for a number of different reasons. Often, surgeons feel secure if they write non-compliance in their chart. Patient's not compliant, they write it in the chart, and they feel as if they'll be protected from a liability standpoint if something goes wrong. And that would make sense to you, that if the patient doesn't follow instructions and something bad happens, it shouldn't be the surgeon's fault. It ought to be the patient's fault, if anyone. Well, just writing non-compliance, as it turns out, misses the point, because that's not what the liability exposure is about. That's not what the lawsuits are about. What the lawsuits are about are that patients are not only non-compliant, but claim that they didn't know better. They didn't know the implications of their non-compliance. Now, remember, ultimately, who judges this are who? Patients. Patients make up our jury pool. 100% of our jury pool are made up of patients. And patients at times are, very forgiving to other patients. And so this works in court. And so we need to take this whole topic of patient compliance, non-compliance, to another level. And that's what we want to do. So if you have a patient who's not compliant, we want you to send what's referred to as an at-risk letter. Put at risk in quotes. I'm not saying you title that at the top of the letter, but that's what it's called, because it's meant for patients who are putting themselves at risk from a health standpoint. Again, it's not a defensive tool. It's a patient-focused tool. But at the same time, you're at risk, because if your patient's at risk for an adverse outcome, that's not good for the patient or you, and it's not good from a liability standpoint. So we want you to send an at-risk letter. That letter will have in the first paragraph an explanation of what the non-compliance is. Just put it out there in a line or two. Importantly, the second paragraph, you'll set forth the implications of the non-compliance, that the infection's going to get worse, that their condition's going to deteriorate, or it could be much more serious than that in some cases. Put it there in the second paragraph. In the third paragraph, give them a path to get back on course. Your phone number, what they need to do, what test they need to get, what has to take place next. And you send this letter to the patient. Now, we've done this. All of these tools that we've been talking about today are vetted, which means we talk to business managers about them, we talk to surgeons about them, we roll them out, 50 or 60 practices, and then check with the practices and say, where were the bumps? How did it work? What happened? And we fine-tune it before we roll it out to the universe, surgical universe. When we rolled out this at-risk tool, it was very interesting. What happened is a large subset of patients complied. So when they got a letter saying, here's what you're doing wrong and here's what it's going to cause, they thought that's not good. And they actually got on the phone, set up an appointment, and came in. That's great. That's a classic home run. I mean, that's good for the patient. It's good for the surgeon. It's good all the way around. And that's a pretty large subset. Another interesting subset where patients whose family members would read these letters, and the son or the daughter would get on the phone and say, Mom's not doing what? And what could happen? Where do I take her? Remember, we talked earlier, in bariatric surgery and other types of surgery, the whole family's involved. So when this letter comes from their surgeon, it's not just the patient who's going to view it. It could be, setting HIPAA aside, it could be someone else in the family. And that family could essentially assure compliance. Again, home run. Now, I'm not naive. I'm not going to kid you. There'll be some patients that they're not going to do anything. They're non-compliant. They're going to get your letter. They're going to read it. They're going to be non-compliant. And unfortunately, some of those patients are going to have an adverse outcome. But at least now we've made the record clear that that adverse outcome is not because of something you, as the surgeon, did or did not do. It's not because you didn't communicate to them what they need to do. It's not because you didn't impress upon them the implications of their behavior. It really falls squarely on their shoulders. And that's a very powerful piece of evidence that, if needed, we could use. I will tell you that that piece of evidence often will keep the plaintiff's lawyer, the lawyer that's evaluating this case, will keep him or her from even taking the case. Because they're interested in successful cases, right? They don't want 40% of zero. That's a little number. And so it may keep a certain number of cases from going forward. But if the case goes forward, and some of them are gonna, and now we're in front of patients with that type of evidence, the patients, meaning the jury, is going to say, wait a second, that can't be the surgeon's fault. I mean, that patient was told exactly what to do, and they decided not to do it. So what the surgeon said was going to happen, happened, and now we're going to blame the surgeon? I don't think so. And so we've seen this play out in very positive ways. I think what the group really likes about this type of tool and tools like it is it's focused on safety and quality and the patient. It helps the surgeon too. That's certainly all right. But being focused first and foremost on the patient, I think, is why they've been so successful.